All right, everyone. My name is Troy Evans. I really appreciate everyone taking a few minutes out of what I'm sure is a busy Friday at the end of a busy week. So I am the owner of Industry Lab Diagnostic Partners, shortening that to make it a little easier. Industry Lab here in Cincinnati, Ohio. For those of you that don't know, we are a clinical reference laboratory focusing on infectious disease and toxicology, and really the provider. And in reference to that, we have started a new educational experience and offering these town halls throughout the month of July and August. We believe that we only do things that add value. And and our presenter today will add value to not only internal people of Industry Lab, but also the most important people that we care about are our clients and our providers. So these town halls are open forum. Dr. Michaud will present, and he will use a formal slide deck, but we will have an opportunity to communicate at the end and ask questions, and I'll do the best I can to surmise those and make sure they get out there. If they do not, then I will reach out to you personally afterwards and we'll address your question directly. Okay. So without further ado, I would just, like to have a few housekeeping notes first. During the question and answer phase, I missed this the first time. Sorry, but there's a little activity button on your lower right-hand side of your screen with some simple shapes. If you click that and you go about 3 or 4 down, it'll say Q&A, and you can ask your questions in there. You can also raise your hand, which is at the bottom of your screen, if there's a pause in the activity or during, and I will make a note of who raised their hand, and I'll either come back to you, or when I get a break in the action with Dr. Michaud, I'll ask that question. Okay, so we'll do the best we can. Again, second time is the best time. Doing the speaking today and presenting to you is our director of clinical treatment. He is a dual board certified and clinical pharmacist, practicing infectious disease and treatment options for intensive care patients in Spectrum Health for the last 14 years. And personally being the owner of Industry Lab, and being passionate about this position in our lab, a great resource for not only our staff and our scientists, but also our clinicians and clients. So, Dr. Michaud, the table is yours.
Perfect. Sounds good. Yeah, welcome everybody. I guess I'll get started, and thanks for the introduction with a very quick slide. Essentially, what is the director of clinical treatment? If you saw that title on the front, it's a great question. I have seen a lot of PCR practice across the country, and I don't think I've seen this title in any other lab either. But this is essentially what drew me to industry and why I'm here now. Most labs, I think, see their job as receiving a sample, testing it, and kicking out a result. And once that result is there, that it is out of the lab has done their piece, and it is for the providers now to decide how to use that or what goes next. We take the approach, and the reason I'm here is that our commitment to that patient or that sample ends when the patient is treated well. And when somebody uses this result in the best way to treat somebody well or to not treat somebody in the case of not needing antibiotics. And we also work on the front end. PCR, some people on the call may be very familiar. Some people may never have used PCR, outside of COVID testing in the last couple of years and not really have an idea of where it is. So we try to help educate as well. And that makes us a clinical lab, is trying to be a partner with people Because again, what we want is to provide for better outcomes and be a part of good outcomes for patients. I'm here because I really believe PCR can do that, and I've never seen a lab do it as well as industry. So that's why I'm speaking to you guys here today, and I'm really excited to get into this. We're going to highlight UTI and sexually transmitted infections predominantly. PCR is available to a wide range of disease states. And so this is just meant to be a quick overview of these, kind of a focus on these two. And I'm looking forward to doing more of this, educating in different realms like respiratory and gastrointestinal illness and other areas where PCR can also be a useful tool. So with that, this is all of my stuff that we do not have to spend any time reading. And let's jump right into it. So I certainly won't insult anyone's intelligence by reviewing what culture is. Culture is the world that we live in. It's the world we've lived in for 70 some years now, essentially, in medicine. It's the world that I live in day to day, and in hospital practice, it's how I grew up in infectious disease, just like the rest of us. And ultimately, I'll just reference culture to say that not a lot has changed. Technology and culture has gotten better, of course, but the concept of culture is the same as it was in the 1950s when it became standard of care for UTI treatment. And that's the idea of saying, you have something in this urine, but we don't know what it is, and we can't identify what it is. So we need to handle it very carefully. We need to give it food. We need to give it heat and light, and we need to take really good care of this so we can grow whatever is in here, and then we can identify it. And obviously, if you just think logically about that and scientifically, that brings a lot of inherent limitations to what can be done there, because not everything grows on that plate. Not everything eats the same food, and a whole other list of reasons why that makes it difficult sometimes to identify what we've got inside that sample. Again, the general timeline that we're all very familiar with, but is important to consider when we compare this to PCR. A couple of days generally for culture, and usually an additional 24 hours or so to drop antibiotics on that and test them, and then get those sensitivity results that help guide treatment. So ultimately, again, I'm not saying culture is bad, or it's what I do every day. It's what we all do every day still, to diagnose infections. But the drawbacks are very objective, and they just are what they are, and we've worked around them forever. This multi-step process really only has a sensitivity for detecting UTI in about 75 or 80% of cases. And we've all been there with a patient who, you will bet your license, this person has a UTI. They've got every symptom, they got classic presentation, you definitely have a urinary tract infection, and we get a negative culture. Or worse, we get recurrent negative cultures in a patient who ends up with recurrent symptoms or refractory symptoms. That is the output of this growing things process, when we know not every bug will grow on these plates that we put them on. These plates also favor common things, and that leads to step one as well. These plates are great at growing E. coli, and that's good because E. coli causes a lot of UTI, but it doesn't cause all UTIs. And so if you have an organism that doesn't eat the same food as E. coli, it's less likely to grow enough where we can identify it. So we never get to know what is in that sample by culture. One other piece that we really have learned a lot about in the last 10 years especially is that many UTIs are the result of more than one pathogen. Some reports put this up to 39%. Many of them listed in the 20-30% range of all UTIs are caused by more than one bacteria or more than one organism. And this makes sense if you think, again, just rationally, if you put two species on the same plate and tell them to both eat food and both try to grow, it's common where one of them can do that better than the other. And that E. coli, for example, can out-eat a ureaplasma or a Pseudomonas or a Serratio or something less common, and therefore that other species doesn't grow. And by the time we're actually looking at this 3 days from now, all that it says is E. coli. And we treat the E. coli, but that patient doesn't get better. Why is that? Because there was something else in there. Culture just couldn't give us both, or sometimes all three of those organisms for us to be able to see. So I say that to sort of set up PCR, just so that we can look at the technology differences here. Again, some of you may be familiar with PCR, some of you less so. but this is molecular detection now of organisms. This is DNA-based detection. This is what we've always kind of said throughout all of our training. Sometime in the future, we'll be able to do this personalized medicine and this DNA genome-based medicine. Well, PCR is essentially our step into that realm, one of the steps that we're taking into this realm. And just a quick video, again, if you've never seen it, we know the genetic code for, let's say, E. coli, or for any of the organisms that can cause UTI. So during PCR, we essentially split that DNA. We have an enzyme, this polymerase, that can essentially replicate it and cause more strands. And with every cycle of PCR, is the terminology here, we can effectively double the amount of DNA that's present. So you do that 20 to 30 times, and you can end up with truly over 1 billion copies of that DNA, which allows us to very, very accurately identify what is in there and what is not in there. So one of the main highlights for PCR is that it's not just about bacteria anymore. If it has a genome, you can test it, and you can test at the same time. So that allows us to look for all of these things essentially in one test, from one urine sample, or from one vaginal swab, or one sputum sample. You can look for all of these causes of infection at the same time, because it's not about getting it to grow anymore. We can simply see what's in there right now. This total test as well, depending on how many things you're looking for, essentially, is done in a matter of hours. And industry makes it a priority to get results back to you in less than 24 hours. So instead of this timeline anymore, where you're waiting 2 or 3 days for a less reliable test, PCR essentially introduces the ability to test more broadly, more accurately, and more quickly. And you see it here, the sensitivity and specificity of PCR is greater than 95%. And there are very few diagnostics in infectious disease or anywhere in medicine that can say that they are this sensitive and specific. This table is essentially another way to say a lot of that if you're more for table format. And I would also highlight this over here. We know that cultures have trouble if you already have antibiotics on board, because while you are transporting that sample, while it's trying to grow, you already have Rocephin or whatever antibiotic in there actively killing that organism. So it makes it very difficult to grow through that. PCR is not affected by that. PCR is more kind of stable and more solid in a lot of ways than culture, because again, we're just looking for the DNA. And so we don't have to handle it so delicately. I would say we don't have to worry so much about, having make sure that it's always moving, or that we got to get it to the lab in the next 30 minutes, or it's not going to be viable anymore, because we're not worried about keeping that E. coli alive and healthy to make it grow. We can find that E. coli DNA under a lot of circumstances. So there's a lot of just practical advantages ultimately to PCR2 when it comes to sampling. The other thing that's really nice about PCR is that something else has genomes, and that is resistance. Every mechanism that bacteria or fungus or anything uses to be resistant to antibiotics is the result of that organism creating some sort of protein, right? And then having that part of its cell wall or wherever it's having its action. And all of those resistance mechanisms also have genetic sequences to them, have DNA. And we know what that DNA is. So in addition to testing for a huge range of pathogens, if we want to test for a huge range of pathogens, we can also test it specific to our urinary tract infections here, up to 41 additional markers of this resistance. So not only within 24 hours can you know what is in there and what's not in there very accurately, but we can also tell you what drugs to avoid because we have detected the resistance to this drug. So we can take that 3 or 4 day culture process, kick it back in less than 24 hours with, again, better sensitivity and specificity. So it's a very exciting realm of using PCR, again, not just for COVID or not just for tuberculosis or these kind of one-off scenarios, but using it for these kind of broader infectious disease purposes like UTI. You don't need to take my word for it. Again, I'd like to think I'm quite objective and I'm evidence-based, and a lot of people dislike that quality sometimes. I really drive that home. But again, the data here is really not my word for it anymore. You can start to find pretty big data. We're not even in case series land anymore, or 50 patient study land. This data is coming along, and it's getting to be pretty big. These are just 3 examples with thousands of patients in them. Meta-analyses now are being done to pool this data together. And what these papers consistently tell us is that where cultures are negative during actual infection, that's 75% sensitivity, PCR is not. So gone, kind of essentially, are the days where we don't have a direction. And sorry, we just got to keep you on broad antibiotics for 7 days because we don't actually know what's in there because our culture was negative. Again, these continue to highlight what we talked about a lot of UTIs being polymicrobial. Culture misses most of them, and PCR does not. PCR can find 10 things if they're all present in there. There's no limit to that. The speed that we talked about, and ultimately, the data is finally starting to show us that all of this put together actually starts to lead to improved outcomes, and particularly when it relates to antimicrobial stewardship. And this is really where the sensitivity and specificity partner, because now if you get a negative study, you can get rid of antibiotics, and it's not day 3 or day 4 that you're getting this negative study. It's on day 1, effectively. It's less than 24. And I talk to people every week that said, this person hasn't even taken their 2nd dose of Bactrim yet, and I'm going to stop these antibiotics because this if it was there, PCR would have found it. So I have this negative report in front of me. I'm going to save this patient 6 days of antibiotic therapy, and that's a good thing any way you cut it. And there's all kinds of data to tell us that that's a good thing. We can also go from broad coverage to narrow coverage faster, both in the inpatient setting, certainly, and even in the outpatient setting, where we can use less augmentin, we can use less doxycycline, because we can hone in to amoxicillins or Keflexes or something when we know definitively that that's the type of bug that we're looking for. And again, less antibiotics, we all know, when they're not needed, is a good thing. So here's a couple, again, cases that we see every day. And this is what I do every day is look at PCR results and apply them to real patients to yield real antibiotics. And then we follow these real outcomes. Consider the elderly patient with altered mental status. This might be somebody you see every day. This might be somebody you see rarely in your practice, but you can understand this scenario. Altered mental status, we have to rule out UTI in a lot of cases, right? So what do you do when this is the result? This patient gets put on antibiotics, urine culture gets sent, and 3 days later, the culture is negative, but the patient is better. So what happens in that? Do you stop those antibiotics? Even as a clinician, I would say no, right? It's hard to say we're going to get rid of these because of a negative culture. We know that culture is wrong a quarter of the time, and this patient is better. So that patient's probably getting 5 or 7 days of antibiotics when they may not have needed any at all. If you send that for PCR instead, because of that better sensitivity and specificity at 24 hours and the turnaround time of 24 hours, you can get rid of those antibiotics pretty confidently the next day if you get negative results. And if it's positive, you can narrow to something that is not more than is needed. So there's a lot of utility in some of these spaces where we feel compelled just to give empiric courses because we don't get any information from culture. A different example, just your typical routine outpatient, right? Not a complex patient, a young female maybe, whoever just comes in, they look like they have a UTI. We'll take a sample and we'll send it, and here's some Bactrim, and to home they go. 3 days later, we realize this is E. coli and it's resistant to Bactrim. Maybe if you've got this young female, that's probably not a problem. You change to something else, and this patient probably recovers. But as these patients get older and older and older, we know the time that we spend mistreating an infection or missing with our antibiotics causes worse outcomes. So you send this exact sample for PCR instead, we find the pathogens and the resistance markers, and indeed we found the Bactrim resistance. We also actually found cephalosporin resistance on this isolate. And before the patient got their 2nd dose of Bactrim, we were able to switch to macrobid, and this patient had a good course and symptoms resolved. And finally, maybe a little more of a niche patient, but you think of an elderly patient who has recurrent UTIs, like a BPH patient or a chronic catheter patient, somebody who we're doing this multiple times per year. And in some of these cases, you get recurrent negative cultures. So again, what does this mean? This means a lot of antibiotics. and you hope that you're hitting the right things with these antibiotics, but we don't really know because we don't get data to drive that decision. This is, again, a real example. PCR is run for this patient, again, after many courses of antibiotics, and what comes back is a ton of ureaplasma. Atypical, not a common cause of UTI in the overall population, but a pretty common cause of non-gonococcal urethritis, a pretty common cause of male UTI when you have altered anatomy or when you have, difficulties in the urinary space. And so we can get them on something that actually treats this, which is not a typical UTI antibiotic that we would just pick empirically, and this patient can finally have symptoms resolve. So this is for the routine patients. This is for the more specialty patients, and it's certainly for any of these patients where conventional culture methods or conventional empiric treatments have failed. So speaking of, again, we could talk UTI for an hour or a day unto itself, and I would love to do that. If anybody call me anytime, email me. I can send you data. We can talk about data because, again, it's not my word for it. These are kind of evidence-based now things that we are employing at Industry Lab. So speaking of ureaplasma, that's a good segue perhaps to STI. And STI is a little different when we talk about PCR because we're already doing PCR. The whole medical community is already doing PCR. So it's not that this is a new technology. If you're already ruling out chlamydia and gonorrhea and trichomonas and some of these other STIs, wherever you're sending them, or if you have a lab in your health system or whatever, they're very likely already doing STIs. That's already regarded by the CDC and the IDSA as the standard of care diagnostic tool for these. What we do then at Industry Lab is, again, be more clinical to this. So we look and say, in what settings, what patient populations do you need to use these tests? What other tests do you need to use? And how can we make this easy so that more patients can be tested and screened and then treated quickly and appropriately? To look at some things that we probably don't need to look, we don't need reminders of this, but these, again, are from the CDC website, which is a great resource for STI info if you've never been out there. 1 in 5 people have an STI. Obviously, this favors the young population. It favors the female population a little bit unfairly, and it costs a lot of healthcare dollars and causes a lot of healthcare morbidity, even now for all that we know about it. Here's some prevalence and incidence. Of course, we know some viral STIs are not curable, at least yet. So we have a lot of cases per year still. But even trichomonas and chlamydia and gonorrhea, we're still talking about millions of new infections per year, many of which are the result of community spread from people who don't even know that they have the STI. And that's really one of our focuses, is how do we get the asymptomatic patients more access to STI screening so that they can know, they can get treated, and community spread can stop right there. This is just a sample to show, again, if you've never seen, that so many of these STIs are asymptomatic. And again, this unfairly leans towards women, that they harbor the brunt of this. Any of these disease states, we're talking about 50% or more of patients not knowing that they're infected. And so spreading it often to sexual partners without knowledge that they even have it. And most of these are the treatable type. This is chlamydia, gonorrhea, trich, that is getting spread because they just don't know. So curbing the epidemic, again, is less about how to test. PCR is how to test. That's already established. In our mind, it's more about getting access, again, for these people to get screened if they're in a population who is high risk for getting these infections, or they're in a location or a community that has high prevalence of these tests, so that they can find out when they have them and they can get treated. Obviously, in women, this is even more important because they suffer the more ramifications of untreated STI when it relates to pelvic inflammatory disease and fertility, baby transmission. So obviously, it's important in these women, certainly even more than men, perhaps, for their own health, to make sure that these things are identified and treated. So again, part of what makes us a clinical lab is that we like to be educators. This is part of my job, is to try to give people some of this information. None of us essentially, go into school or in a specialty that specializes in STIs. It's just part of our job, kind of wherever we are. If we're family practice, or we're in urgent care, or we're in behavioral health. STIs are something we all interact with, but it's not necessarily our wheelhouse all the time. And so I would love to supply you with these things, because these resources are out here now. And particularly the CDC resource at the bottom, it does a really nice job of laying this out by saying, who needs to be screened. Again, in the absence of symptoms, you're not here because you think you have an STI, but you're a sexually active woman under 25. You should have chlamydia and gonorrhea and trichomonas tested for at least once a year to make sure that you are not harboring an asymptomatic STI that you should just otherwise get treated for. And they do a great job of laying out these very simple patient populations that we should have this screening in mind for. They also lay it out by disease state. So again, you can look at women, pregnant women, heterosexual men, homosexual men. And there's a lot of data out there now and synthesized in these references to tell you who and how often should be screened for these diseases. And some providers I know are uncomfortable having that discussion. We've got resources for that too, if they're helpful. Again, our goal as a lab is not to invade your space or those conversations, simply to just improve the health of the people that we serve and that use our tests, and make sure that access to these tests is not a barrier. So that's what we have done, and we'd love to provide these for anybody who is interested in using them. On our side of the coin, then, as it relates to this, we have designed products or tests essentially to not be too exhaustive, to not over test, and really to gear themselves towards these populations. So if you have a symptomatic patient who comes in with symptoms and a history, and this person has an STI, now if I wanted to test for all of this, even in my home health system, I would need to send probably, I think, 3 swabs to 3 different places. These 2 would be one, trichomonas would be one, and my health system would even fight me to test for these ones. I would have to prove that it wasn't these first and have this patient come back 2 days later to get a different sample, all of those things. So we bundle that together because this is what's clinically relevant. This is what matters to this patient. And you can know if any of these are positive or negative in less than 24 hours. We also try to make it easy to test. Of course, a vaginal swab would be standard for this, but when you talk about the homosexual male population, it's important to look in other areas for these infections. So we validate these tests beyond just the one validation. We go further to validate multiple sites so we can find the disease where it exists in these patients. We also know in some settings, not everybody is doing pelvic exams. Not every patient will submit to a vaginal swab, especially when they're not there for an STI. If you're just here for respiratory symptoms, but you're a sexually active female, who's 25 or less, and you say, hey, it's actually recommended that we just make sure you don't have one of these things, they might not be willing to give, in some cases, a vaginal swab or sample. So we validate these through the urine as well. So that a simple urine sample is all that is needed to be able to detect these and to get, especially, again, these asymptomatic patients, speedy treatment for their own health and for the health of the people around them. We also have a viral screen that we will have on board, because similarly, there's patient populations who, of course, need testing for these, but also need screening for these when they are in high-risk populations or high-risk lifestyles. Again, all defined by the CDC and a lot of data to suggest who should be looked at for these. We don't combine this into some giant panel that costs $1 million. We just want to know hepatitis, HIV. So we've created a product specifically to target that population or to benefit that population. We also have this lesion PCR. No brainer that we would often rule out herpes in patients who have, obvious lesions, external lesions and symptoms. But we bundle chancroid in here. We even bundle syphilis in here, which is an exciting new era for PCR, because syphilis, if you've ever had to test for it, is notoriously laborious and time intensive. And I would challenge anybody, even some days, including myself, to be able to recite how to test for syphilis, because it's multiple serologic tests looking for antibodies. If one is positive, do you have to confirm it or do you not? Which one is which? It's confusing. And so PCR allows us the ability to say, we don't need to wait for antibodies to develop. We don't need to wait till this patient has been infected for 3 to 6 months to be able to find it, we can simply look for the DNA of syphilis, which is Treponema pallidum. And we can find this in as short as 7 days after someone has been infected. So again, kind of a newer area in infectious disease testing, but an exciting one. And we are trying to be clinically relevant. So we are stepping up to the plate to bring this out so that we can try to identify primary syphilis earlier in these patient populations so they can get some simple treatment and we can try to cut into the spread of syphilis. We also have an HPV product coming for populations who would interact with that or would need to screen for that. We'll obviously look for the common subtypes. And these make up about 75% of disease. And we'll also bring in the whole gamut, the whole array of testing. So again, we can feel confident that we are finding this disease if it's present in your patients. So with that, I would move kind of to our final little piece here, which is, again, kind of our philosophy as a clinical lab, trying to make this accessible to patients. The majority of PCR labs will say, hey, if you have a UTI, we've got a UTI product. And it looks like this. This is what our UTI product looks like. And in truth, this harnesses the power of PCR. It can look for all kinds of things, aerobes, anaerobes, fungus, atypicals. I mean, this is slam dunk the benefit of PCR. But as many things in healthcare, one of the major limitations that holds this back from widespread use is cost, right? This is new technology. It's powerful, fast, accurate technology. And so it costs. And I wish that wasn't the case, but there's also no point in speaking around that because it is what it is. And so again, most PCR labs are going to tell you, this is what we've got. If you've got a UTI patient who's low risk, a UTI patient that's super high risk, first time, 10th time, order this for us because this is what we can do. And we at Industry believe we can take a better approach, again, to make this product more equitable, more accessible to more patients. So what we did right off the bat was say, especially in the UTI space, we know that about half of that list causes the vast majority of infections, especially when you talk about the common patients, lower risk, not recurrent, not weird anatomy, not chronic catheter, but the general patient who comes in with UTI symptoms, it's often one of these bugs. So right off the bat, by cutting half of those pathogens, we've cut the cost of this test in half already. We said we can do better than that even. And we take these bugs and we split them into tiers or levels, if you will, to become what we have is rapid reflex testing. Where if you order this for these patients, what we'll do is first, we're just going to test for the most common, essentially 3, genuses or 4 or 5 species of bacteria, because we know this causes 80% of UTI. And so if you're a young, healthy female and you have an E. coli UTI, instead of sending for this, $1,000 almost giant UTI test, we'll test these first. And if they have an E. coli UTI, then you're out the door with a tiny bill because that bill is only going to encompass this testing. If it's negative, we'll say, okay, we'll go on and we'll test the next small group. And these are the next relevant pathogens. If it goes on again, we'll test the next level of pathogens, so on till we get to the end. And the bill for this test that would go to that patient's insurance is only going to be for however far we have to get down this rapid reflex chain to find what that patient has. So what's that going to mean? That's going to mean a lot of bills in this space up here. And we can take a look at how this applies to all of our other products. This level 1, we looked at UTI, but even if you look across the rest of these disease states, comprises your most common bugs. We would love for most people to be found here because that limits the healthcare dollars that need to be spent to find this test, again, rapidly and with a lot of sensitivity and specificity. So we can do this in STI. Like we referenced, if you were in my health system, you would come and we would treat you for these 2, right? We would give you Rocephin and Azithro, and we would send out for these. And if they're negative, unfortunately, but you had STI symptoms, we will call you back to try to get another sample so we can test for these. What we at Industry say is send us 1 sample and we'll look for the common things first. And if they have chlamydia, then the test is done. We'll tell you they have chlamydia and we won't even go here. But But if this is negative, we will automatically go into this next level of testing for you, and you'll get all of this information back in that same less than 24-hour period. I'm really excited for what this means for people in respiratory land. We could talk about this for, again, another hour, but what are the things that we're going to have to rule out for everybody who comes in with respiratory symptoms this fall? Flu, COVID, RSV. And for many places, some places can do this stuff even in an office, perhaps with a rapid test, but when it's negative, what happens next? And so again, rather than a giant respiratory panel, that means $1,000 bill or $1,000 charge, I should say, not a bill to the patient, but charge to people's insurance. We can say, let's look for these things first, but in the patients who are negative for these, let's go further and we'll look for strep throat right away. We'll look for other common viruses right away, and then we'll get into the common bacteria. And your bill, with a little kind of a preview it's shown here, is only going to reflect how much testing we needed to do. So these are the bills, and this is truly the literal cost of doing this in this way. When you consider, again, a lot of these PCR labs with these giant tests, which do have some utility, I'm not saying they're bad things to have, we still have them. And I think if you are a young kid, or if you're immunocompromised, or if you're an elderly patient, it would be good to test for serratia. It'd be good to test for Staph aureus or some of these more drug-resistant things. But for the 30-year-old, 40-year-old, 50-year-old healthy person, you don't need to spend $1,000 on that test every time. This allows us to make this technology, which I feel so strongly can improve our outcomes with its sensitivity and with our speed. It makes it affordable. It makes it usable and reachable for all patients, regardless of insurance type, regardless of donut holes, regardless of all of that kind of stuff, because these are bills that justify it. And if you think about it, even in UTI space or respiratory space, the cost of having that negative culture at 4 days, and now this patient's going to get antibiotics for 7 days. You only spent maybe 30 or 50 or whatever the cost is for a culture, all included. But what's the cost of one episode of C. diff? What's the cost of a patient getting worse because our antibiotics missed, and so that patient ended up in the urgent care or ended up admitted, worst case scenario, where I work in the inpatient side. What's even the cost of them just having to come back to the office another week to say, I'm still having the same symptoms and I need a new prescription and all of that. So with this rapid reflex, that's why we're so excited about this, because this makes PCR, which is unquestionably a level up in terms of technological ability to detect infection, more accessible to more patients. And that is our goal, to make PCR usable for patients, no matter the setting, no matter the coverage, that this can be technology that people can use. And we think rapid reflex is a huge step towards doing that for patients. I should also say, if the test is negative, if we tested this level and this level, and we went through all of this and we did this testing, the bill is this level 1 test. It's not this level 4 test, because we did test all these bugs, but the charge through industry is only going to be this level 1 test. Again, a commitment to making this equitable, making this accessible to the people in the communities that we're testing. So final word, again, I don't like slides that have my own name on it, but we have a clinical arm, as you figured out, at Industry Lab. And we want to help people make sure that our results are treating their patients effectively and appropriately and leading to good outcomes. So if ever you get a report and you want to lay a second set of eyes on it, or a patient has a lot of allergies, or whatever the clinical scenario might be, heck, if you don't get a report and you just want to talk more about PCR, you want to get some resources sent to you, we have a line that's always available to be a consult service. This is what we do 24/7. It's not what most people do 24/7. And it is a new kind of language, so to speak, a new way of looking at this. So we are here to help. We're here to educate. We're here to try and make sure your patients get treated better. So if this is ever of use to you, please feel free to give us a call so we can make sure that PCR is being utilized to its fullest potential for your patients. And with that, I will hand it back over to Troy, and we'll take any questions that may have come up during the presentation.
Yeah, wow. Great job, Dr. Michaud. That was excellent. Obviously, being in the position I am with Industry Lab, your passion and education for this product, for this testing, speaks very loud. So my job is to now do the best I can to surmise some of the questions that we had through the presentation, and I'll attempt to do so now. We'll start with this is a nurse practitioner at a primary care office in the Canton area of Ohio, and is new to PCR, admittedly, although certainly is aware and educated on the testing, and used during COVID quite a bit, like lots of us experienced. But traditional primary care is what described here, middle class environment, seeing all types of patient types. You did a good job of articulating UTI and STI, but mentioned other testing areas for this technology. What do you think would have the best clinical value, I guess, for this nurse practitioner to start to utilize PCR testing in their practice?
Sure. Yeah, that's a great question. There's many, and I think the populations that you see predominantly, we have the ability to test for those. We have, again, UTI is a great place to start, largely because we're very familiar with conventional UTI testing, the culture method and using urinalysis and all of that. So to be able to take that patient, even if, again, you've got a refractory patient, maybe somebody who you've already treated once, they're back, or they have recurrent symptoms, to see what PCR can do, because to see if it can identify something that culture did not identify. And that'll also allow you to see the resistance genes in action, to see how we can accurately tell you how you can treat this patient in that same 24-hour window. So there's a lot of power and a lot of clinical utility in UTI, because because of sheer volume, because there's so many patients that suffer from UTI. And this allows us to treat those patients better. But even the respiratory space, obviously coming into the season upcoming, give that a try, because you'll be impressed. That's what we want to know about respiratory, right? Is it a virus or is it not? Or is it a bacteria? And we want to be sure. And we have the rapid flus in our offices and all of that, but our ability to rule out up to, I think it's 24 respiratory viruses, 22 respiratory viruses, knowing that tomorrow gives you, or ruling them in, we can now tell you there's the metapneumovirus in here, there's parainfluenza in here. And so you can very confidently say, this is viral, we don't need antibiotics here, supportive care, and let us know in a week or so if you're not better. That kind of just gives more confidence to that. The other big realm is women's health. And some of this, obviously in the OB world, they see this every day, but certainly in primary care, you see a lot of vaginitis versus UTI versus STI, some of these vague descriptions. And the power of PCR in the women's health space, we didn't talk about that at all, is also a really, really cool place to use PCR, a really strong place to get a good diagnosis. So really, I would say those probably are the top 3 places in primary care.
Okay, great. And just to, again, surmise Dr. Michaud's answer, that was UTI, which we talked about a little bit more extensively today. And more specifically, he talked about those recurrent UTI patients that you might see. He talked about, and this is certainly going to become more relevant as we get towards the fall here in this area of the country, but respiratory. He talked about utilizing PCR and really kind of identifying viral versus bacterial respiratory infections, which we know will become very, very prevalent in a primary care setting here soon. And then last, but certainly not least, and one of my favorite areas for this test type is women's health. And he didn't talk about either respiratory or women's health today, but those are the three that he identified for great utility in those primary care settings. So thank you.
Troy, I should, as I'm thinking about it, I should add a 3B to this, because the other population that, no matter what setting you told me you were in, should be on that list is STIs in terms of screening patients. Because I think that's a great place where we underutilize the screen. In a patient who's here for respiratory symptoms or for UTI or whatever, if they're a sexually active woman under the age of 25 and they haven't had those things screened in the last year, she should really be screened for this. That's what the best data says. So we have that tiny little screener, and we can do that through a urine sample, and we can tell that patient, this is for your health, and this is recommended. And so there's a huge opportunity to screen more of those patients and find that asymptomatic disease like you're talking about. So I got to add that too.
Great. All right. Are you done now, or is that?
Yes. Yeah. That'll do it.
All right. Perfect. No, that was great. So just again, adding that STI component, and that was actually a great segue for our next question. And I'm going to take you off the hook here, Dr. Michaud, because I think I can answer this one. Perfect. And you can interject if you need to, but it's a great question. And it's another thing that we commit to here at Industry Lab. The question just generally states, Dr. Michaud, thank you for today for the wonderful presentation. You referenced some data and clinical papers. Does Industry Lab provide them or provide a resource to access them? I can answer this. Dr. Michaud said it at the end. You can reach out to him via his hotline, and you can reach out to him via calling our lab anytime you want. And you can also access all of these things, including this presentation, clinical resources, our blog, clinical papers that we identify as relevant to our clients and to best clinical practices, videos, all on our website, ILDP.com, in the resources tab. And that is constantly evolving. So you'll see our products, you'll see the disease states that we test for, you'll see a lot of information about our growing toxicology. It's a great resource, and we try to make it a better resource, and we'll certainly have any input or take any input on that as well. So again, at our website, you can find all of this, including this recording and all of those clinical papers that you referenced. Okay. So I took you off the hook for that one, but I don't think, I think you're the appropriate person to answer this last question. This one is a little bit more specific, and it's something that I know you're very passionate about it, and you hit on it in your presentation a little bit with resistance genes that we identify. But the question here is again an anonymous question, but are you able to show what antibiotics can be or are not to be used based on your results from the PCR tests?
That's perfect. And at risk of this looking staged, I that was something I wanted to talk about during UTI, and I just couldn't get it in without going for too long.
Okay. Yeah.
So I do have a slide afterwards, in anticipation that somebody might want to see it if they haven't before. And so yes, so essentially this is what our UTI. This is an example of UTI in what it looks like. And the scenario is not that important, but the idea is, of course, we identify the bacteria. We identify the resistance genes, and then we translate that for you, because these genes all have weird chemical names and all of that. So we translate into what class does that mean. And then we generate this tool for you so you can see what you can use. Obviously, things in green are things that have activity against both of these bugs that we're generating. Things in yellow, some of these antibiotics will treat one thing, like Cipro, for example, will treat E. coli, it will not treat that group B strep. So you can see it here. And then drugs that you should not use are in red. And that's because either the drug never works for that, like here it is Flagyl. Flagyl will never cover either of these. Or here is Bactrim, And Bactrim would typically use these, as you can see by these circles here. But because of this Bactrim resistant that we found, we have said, obviously, don't use that. And this patient is resistant. So yes, this is the tool that we use to give you an idea of what's on the table, what's not on the table. And then, of course, you translate this with patient allergies and depending on what classes you want to do and everything else you know about the patient to figure out which drug you want to use. And so this is what you do in 24 hours, less than 24 hours in the industry. Yep.
So in probably two simple terms, but to surmise that, green is go. Green is all relevant and all good.
Yep. Essentially.
Okay.
Yep.
Yeah. Okay. Well, great. We are cognizant. These are meant to be quick, jump in, jump off, a lot of information in a short time. Dr. Michaud introduced our new product, Rapid Reflex, today, and we had some great questions. We do have a couple more questions that were sent in, but we will reach out to those people that asked those directly. I picked the ones that I did not necessarily know who was asking them. So we'll get back to those. We want to be respectful of everyone's time on a Friday afternoon. Thank you so much, Dr. Michaud. Thank you, everybody that was attending today. And again, if you have any questions at all after you've watched this again, or if you just didn't want to ask them in this setting, any of the things on the screen today are right now currently on this slide, I will promise you will be responded to. So thanks a lot. Have a great weekend. Thank you, Dr. Michaud. I appreciate it. And best of luck to everybody here. See you.
All right. Thanks, you guys. Bye-bye.